Greetings everyone, my name is Taylor Randell and I will be presenting the topic, identifying how differences in gender and sex affect outcome of patients with hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is an inherited disease of the myocardium. It is a condition where the heart muscle becomes abnormally thick, making it very hard for the heart to pump blood. Hypertrophic cardiomyopathy can also go by the abbreviation HCM. Here are a few symptoms of it. Some people have no symptoms at all, but others can experience these symptoms such as shortness of breath, chest pain, changes in the electrical system, fainting, and heart murmurs, especially during physical activity. HCM is generally caused by changes in genes that cause the heart muscle to thicken. It is usually passed down through families. So for instance, if a person has one parent with HCM, they have a 50% chance of having the genetic mutation for the gene. HCM can lead to a number of complications such as atrial fibrillation, blocked blood flow, mitral valve disease, heart failure, fainting, and sudden cardiac death. The first article I will be presenting is sex-related differences in exercise performance and outcome of patients with hypertrophic cardiomyopathy. The purpose of the study was to evaluate sex-related functional capacity, assessed by exercise echocardiography and its relevance to outcome. Women are less represented than men in HCM cohorts, ranging from 42 to 22%. Exercise performance is known to predict outcome in HCM. This was a 12-year study from January 2004 ending in June 2016 that evaluated 292 adults with a clinical diagnosis of HCM. 211 of them were men and 81 of them were women. The patients were followed up on an annual basis or more often if it was clinically required. HCM was diagnosed in the patient if they presented with a non-dilated and hypertrophic left ventricle with end-diastolic wall thickness greater than or equal to 15 millimeters. Genetic testing was performed in 224 of the patients. Patients with known obstructive coronary heart disease were excluded from the study, as well as patients with the 4 HCM mimics. There were two different types of echocardiography testing done: resting and stress. The first table we review is resting. In the first column, we have the total cohort. The second column is males. The first column is females. And the last column is the p-value. Resting echocardiography consisted of the grading of mitral regurgitation as none, mild, moderate, and severe. As you can see, between the percentages of male and female, they're pretty close. As in none was at 48% for both, mild was at 44% in male, but 46% in female. Moderate was at 7% in male, but 5% in female, and severe was 1% for both. If you look above that, left ventricle volume, left ventricle ejection fraction, and left atrial volume were measured from the apical view. They were measured using the biplane Simpson's rule method. Using M mode in 2D, they measured LV diameter, left atrial end systolic diameter, and maximal end diastolic left ventricle wall thickness. Next, we have stress echocardiography. For stress echocardiography, exercise echocardiography was performed under basic conditions every 2 minutes during exercise to identify and grade mitral regurgitation. It was also used to estimate left ventricle outflow tract gradient with continuous wave Doppler. A 12-lead electrocardiogram was monitored continuously and recorded at baseline at each minute during exercise and after exercise. Exercise was terminated when fatigue, dyspnea, chest pain, or clinically relevant hypertension intervened. In Table 2 at the top, you can see that it is very similar to the resting echocardiography. But here is where we would notice the differences. Between resting and stress, it wasn't a significant amount of changes between the two, but they were noticeable. For example, in males, the severe for resting was at 1%, but now it's at 5%. Same for females. It was also at 1% for resting, but now it's at 4%. In Table 2, you can also view the data for the symptoms between the total cohort, the difference between the males, which was lower than females. Here we have Figure 1. Figure 1 is sex-related differences in functional capacity. Graph A represents a comparison of exercise performance between males and females according to their ages. Graph B represents sex distribution among different functional classes. As we look at Graph A, we can see that exercise capacity was significantly lower in women through each age group. So when we go from 30, they were under men, 31 to 40 was lower, 41 to 50 was lower, and so on. However, peak metabolic equivalents were comparable between sexes in the age classes. But another thing that we must note that makes a big difference is that 72% of this study is males. The proportion of patients with impaired exercise capacity was significantly larger in women than in men, whereas women was at 40% and men was at 13%. Of the 32 women achieving less than or equal to 5 metabolic equivalents, only 4 of them had exercise-induced left ventricular overflow tract gradients, as opposed to 11 of 28 men. At the other end of the exercise performance spectrum, 103 men achieved greater than or equal to 7 metabolic equivalents compared with only 15 women. So as I said before, the difference between the men and the women is big because we have a lot of representation of the men and not so much of the women. Throughout the study, 50 patients were excluded from the survival analysis due to a follow-up less than a year. The remaining 242 HCM patients were still followed. Of the 242 patients, 24 of them met the primary endpoint and 55 of them met the secondary endpoint. So the main result from the study was that exercise performance is more diffusely impaired in HCM women compared to men. The impact of age on exercise performance was very striking in women with HCM. Exercise performance seemed to have a true predictive value in only male patients. However, the study identified that postmenopausal endocrine changes may be the impact on why the women's exercise performance was more impaired than men. The main cause of it can be because of the loss of the protective role of estrogen. However, again, only 28% of the patients were females. In conclusion of Article 1, the main findings of the study was that exercise performance evaluated by stress echocardiography confirms its value in male HCM patients, but it did not have the same role in women, which leads to the findings that female patients with HCM showed significant age-related, specifically postmenopausal age groups, impairment in functional capacity compared to males, which leads to the findings that women are at greater risk of HCM-related complications and death. The findings of this article suggest the need for sex-specific management strategies in HCM. The second article I'm going to present is the impact of sex in clinical course and the survival in the contemporary treatment era for hypertrophic cardiomyopathy. There has been some uncertainty to whether women with HCM are at greater mortality risk from heart failure or other disease complications. The purpose of this study was to evaluate whether there are sex-related differences in clinical presentation or outcome for patients with HCM. This was a 15-year study of 2,123 patients ranging between 20 to 60 years of age. The study included patients with a clinical diagnosis of HCM with a non-dilated left ventricle wall greater than or equal to 13 millimeters. The study consisted of 38% women and 62% males. Patients with known phenotypes of HCM were excluded from the study. Here I present to you Figure 1, which shows the differences in diagnosis between men and women. At the age of diagnosis, women were particularly older than men. Women also had a significantly higher amount of advanced heart failure symptoms than the men did. As for left ventricle, the differences weren't significant, but women still had more. And again, women were also in the lead for myectomy or alcohol ablution. On the right side, we have the similarity between the two sexes where they were both running tight races. For a change, the sudden death events were higher in men than women, as well as the atrial fibrillation, which they aren't significant at all, but they still are a little bit higher. And for total mortality and HCM mortality, they were pretty much even almost. For survival and event analysis, the fraction of patients at follow-up intervals were estimated using the Kaplan-Meier method. As we view the table, compared with men, women with HCM had smaller left ventricle end diastolic and left atrial transverse dimensions. For left ventricle end diastolic, women were at 397 while men were at 436. For left atrial transverse dimensions, women were at 407 while men were at 427. Women had slightly less maximum left ventricle wall thickness. There was no significant difference in the prevalence of extreme hypertrophy, which means that left ventricle wall thickness was greater than or equal to 30 millimeters. And the comparison with that was that it was 5% in women versus 7% in men. Women more commonly demonstrated dynamic left ventricle outflow tract obstruction caused by the mitral valve systolic anterior motion than men did. Women were at 65% and men were at 57%. However, at rest, women were at 45% and men were at 31%. When less frequently provoked with stress, exercise echocardiography was at 20% in women and 26% in men. A total of 351 patients underwent clinical genetic testing, similar in women and men, where women was at 15% and men was at 17%. However, women were more likely to have an HCM disease-causing sarcomere variant identified, where women were at 60% and men were at 44%, which most commonly came from the MYBC3 and MYH7 genes. Overall, the study shows very low mortality rates directly from HCM itself. Women were reported to have an unfavorable outcome with HCM compared to men. However, no evidence was found regarding gender-related bias in recommendations for invasive therapeutic options. And these options include myectomy, heart transplant, or alcohol septal ablation. In conclusion, the takeaway from this study was that there has been a delay in diagnosis of HCM in women. The study suggests that there should be an increase in awareness of HCM for women. Although HCM women are not at greater mortality rate than men, the studies still show that they have an unfavorable outcome rather than men do. Here we will identify the relationship between the two articles. The contradicting matter between the two articles were that in Article 1, it was concluded that women, especially the postmenopausal age group, were at greater risk for HCM-related complications and death than men were. But in Article 2, it states that women were not at any greater mortality rate of HCM complications or death than men are. However, women with HCM are under-recognized and referred to centers later than men. Both articles can agree on women with HCM needing greater awareness that would lead to earlier diagnosis, treatment, and hopefully improve quality of life. Both articles identified how the differences in gender play a role in patients with HCM. Article 1 used an exercise performance approach, measuring it with functional impairment and exercise echocardiography. Article 2 broke down different symptoms and complications, tracking them over years from initial evaluation and so on. Article 2 focused more on mortality rates and how the complications affected the patients. In conclusion, women with HCM should lead earlier diagnosis and treatment because they are usually referred later than men. Women should be more attentive for early diagnosis to receive treatment sooner and hopefully improve the quality of life. Overall, both articles touch key points identifying the effects HCM has on men and women. The articles' methods were similar in a way, but the data was used in two totally different ways. But still, the results concluded from the evidence that HCM is serious for both genders, but women should be more attentive for early diagnosis.